JJ Staiano, plastic surgeon extraordinaire. If you have any questions, plastic surgery related preferably, then please feel free to ask them, and I will do my level best to respond to them in an appropriate manner. But I have got some questions already in the bank, fortunately. Otherwise, I'll be waiting all day. So what have we got? Well, I'll tell you what we got. I'm going to kick it off if that's okay. We have got, can we drain a branchial cleft cyst? So, yeah, so I think I might have said once somewhere, like we can remove cysts from anywhere in the body. No, I wouldn't have said that. But anyway, if I did, there's, cyst just means fluid-filled sac. So there are loads of different types of cysts. And that's one of the reasons we often ask for a scan if you have a cyst or a swelling in a certain location to see what it is and what it's connected to. So we basically will remove skin cysts, cysts that are originating from the skin. And that's fine. We're fine with that. But obviously, if you've got a lump and it's kind of underneath the skin, it can sometimes be difficult to tell where it's originating from. Skin cysts will often have a punctum, a little hole that you can see is connecting to the skin, but they don't always. So you might have a kind of swelling and we might not know where it's coming from. And a branchial cyst is a particular type of cyst originating, usually presenting in the neck, which is one of the reasons why neck cysts or neck lumps, you've got to be very careful about, because you've got to say what is it. So if it's a skin cyst, fine, we can remove skin cysts on the neck, no problem at all. But a branchial cyst is a different story. A branchial cyst is a swelling, but it's actually originating from deep, from the development, from the branchial arches of development. It's a kind of congenital abnormality, and it's not originating from the skin, it's originating from the other side, from deep. So you can't just, so we wouldn't do a branchial cyst. A branchial cyst is a difficult thing to operate, and you're also saying drain a branchial cyst, not a question of draining it, usually it's removing the cyst. So it's actually quite difficult to remove a branchial cyst. It's a specialist procedure. It would be done either a head and neck, well, it would be done by a head and neck surgeon, which might be a plastic surgeon, could be an ENT surgeon, but it would be someone head and neck trained. And it's a different level of complexity to the sort of cysts we do at the clinic, which are skin cysts, where you make a little incision in the skin, you go underneath the skin, you take the cyst out, you can get under. I think I moved my arm. You can, sorry, my setup here is not, could argue, not the most, oh God, professional, but we'll rise above it. Jay wants to co-host. Look at that. Jay wants to co-host on TikTok. Do you want to co-host, Jay? Have I got a co-host in the house? Oh, it's gone. So with the skin cyst, you go through, you make an incision in the skin, you get around the edge of the cyst, and you get to the bottom of it, you get underneath it, and then the whole lot comes out. So that's why we will often ask for a scan, because what we don't want to do is make an incision in the skin, get to the top of your cyst, then start going kind of underneath and realizing we can't get underneath the skin, realizing the skin's connecting to something deep. And the neck, there's quite a lot of deep things it can connect to. A branchial cyst is one thing. There's nerves, there's blood vessels, there's your esophagus, there's your trachea, there's all sorts going on. So we just want to make sure that it's not connecting to something deep and it's not associated with something deep. If it's not associated with something deep, fine, we can remove it. But a branchial cyst is one that's connected to something deep. So a branchial cyst is not something we would do at the clinic. The answer is no, we wouldn't do a branchial cyst specialist thing. I've actually got a question here, which I should answer now. What do you think of Belite implants? That question, it says it's a week old from Instagram. Is it Instagram? 3 likes on my Instagram video. So thank you for liking the video, those 3 people. Getting into the big leagues now. More than a couple of likes, that's a few likes, I think we can all agree. So I've got a few likes on that. So what do you think of Be-Light implants? Have I said that already? That was a question anyway. What do you think of Be-Light implants? Well, I'm not doing breast stuff anymore, so I am not doing that sort of thing. But and you find this sometimes with plastic surgeons. They have a stuff that's not, from a scientific point of view, I think they're good. I think they are, because they're light, basically they're lighter than standard implants, and so I think the concept is good. They haven't really been embraced. I had a problem with a set of Be-Light implants, and when you have a problem, you as a surgeon are sometimes emotionally scarred by it, and so it kind of puts me off them. Rightly or wrongly, they might have been blameless, but still, when you have a problem in a patient who's had them, you do kind of, or at least, it's put me off them. So that's a personal thing just for me, but I think in general terms, I think the concept is good. They're expensive. There was a period where they weren't available, and yeah, I think they're good. I use a lot of polyurethane implants, and at the time they didn't have Be-Light polyurethane implants, but I think they've got them out now. So that would have been, so that's another plus if they do Be-Light polyurethanes. Although I imagine Be-Light polyurethanes are expensive, because polyurethane implants are more expensive than silicone implants. Be-Light implants are more expensive than standard implants, so Be-Light polyurethane are probably going to be really expensive. But anyway, the concept I think is sound. I'll leave it at that. I think the concept is sound, and I think that's a good idea. I think another reason why probably I didn't kind of embrace them was, I think they would probably come into their own for bigger implants. I think that's when the size difference would be, when the weight difference would be more significant on a bigger implant. I personally don't tend to use like really big implants, but maybe if you're one of those surgeons who uses really big implants, maybe the Be-Light would actually have proportionally more of a benefit there. But yeah. OMG, we look so similar. It's crazy. Johnny boy, lucky boy, Johnny, lucky boy. It's not easy, is it? So thank you for that question. I hope you're here this week. You were there last week. What happens if my lipoma returns after having it removed? What do you kind of mean? What happens? I mean, it's unusual, but it has happened, and it has happened to me. Usually on big ones. I suppose any, whether it's the lipoma returning or another one. But anyway, it could be the whether it's the lipoma returning or kind of like a multiloculated lipoma, that maybe we left a bit of lipoma behind. Slightly academic, I guess. Well, I guess the answer is we take it out, is what happens. And one of the things that I've built the clinic on is kind of trying to promote the aftercare service and what have you. So if you do have a problem, so if a lipoma comes back, or if a cyst comes back, or something like that, we'll just remove it. We won't charge you. I mean, it's not great to have it removed, so that's not ideal. But I say it's not common, although as it has happened to me, so I can't say it never happens. Yeah, and whether that was it coming back, I'm trying to think now. Whether that was quite a large one, and as I say, it was sometimes a lipoma is like a really nice, like it's got nice edges and it's kind of obvious, but sometimes they're what we call multiloculated, where they have like little bits that sort of go off to the sides and things. So you kind of hope that you get all the kind of locules or all the bit pieces away, but sometimes you don't, and so there is a chance that we might miss a bit. So if we miss a bit, no problem at all. We will go back and fix it for you, but not sort of really common for it to sort of literally sort of come back after it's removed. That's kind of not a common thing. But bottom line is we'll look after you. So if you have a problem, we'll fix it if we can. Do we offer treatment for rosacea? No, we don't. That would be a so rosacea is redness of the skin, and I've got to be honest, I've got different cameras here. I've got the this one here, which is Facebook and YouTube. This one here, which is, so that's my computer, that's my phone, which is Instagram. Instagram's always got a good image. I don't know if it's because of the phone. And this one here, which is TikTok. But I can't be honest, I look like I've got rosacea on TikTok. It's a bit weird. That would be a dermatologist. And I've often thought it'd be good to have a dermatologist at the clinic. I would like a dermatologist. I was speaking to one the other day, and I was saying, if you want to come to the clinic, do, because I think it'd be a good addition to the clinic. But all of us at the clinic at the moment are plastic surgeons, so that means we kind of do surgery. We cut things out, so that's our forte, cutting things out and stitching it up type thing. So if you have kind of a skin condition, a rash, rosacea, something like that, it would be a dermatologist, which would be a kind of different type of doctor that, and we can recommend and refer you to one, or you can find one locally. But yeah, we don't treat rosacea. Can we remove a pilonidal sinus? Pilonidal sinus is troublesome things which are usually due to little bits of hair. They're commonly in the natal cleft, is a common place for a pilonidal sinus. Little bits of hair, usually from the back, usually in males, get buried in, and they're used to be called Jeep driver's bum, because Jeep drivers in the army would get them because they're sort of sitting all the time and hot and sweaty. Lorry driver's bum, I guess, would be the modern equivalent. But the little hairs that grow in and form this little tract, and it can get infected, and it can discharge, and it can be really troublesome, really troublesome. It's a difficult area to operate on. Sometimes you can get the hairdressers get them in the webs of the fingers, but that's less common. Certainly the most common one is the natal cleft. We operate on someone today who had a thing on his head, and there was kind of hair in it, and I wondered if that was kind of like a pilonidal cyst, but I don't know if you can get them on your scalp. Anyway, well, I did remove that one. So traditionally speaking, the treatment of pilonidal sinuses, pilonidal cysts. So pilonidal sinus is kind of, a sinus is like a cave, an opening to the skin with a cave basically. A cyst is when it becomes a fluid-filled cavity. And strictly speaking, they're difficult to treat. They often need dressings. They often need laying open, which means sort of making a big wound and letting the opening to the cave be really big so that it can heal from the inside out, rather than having a little opening to the cave and kind of infection and bad stuff going in at the depths of the cave. And that's not normally plastic surgeons. It's usually general surgeons. So that would not normally be us. So we wouldn't be the first port of call for a pilonidal sinus. So it would probably, well, I'll say, the majority, or often, they're treated non-surgically, and surgery only comes when they become very problematic. And the surgery is usually around kind of laying open, and then there's quite a lot of work in terms of dressings afterwards, and you often have to pack it, because you have to pack the wound, because you don't want the skin healing up before the depth of the cave is healed up. So you kind of want to keep the skin open so that it heals from the bottom up. So you often need regular packing, which is done by the nurses, and it's quite intensive. So yeah, we tend not to do that. We certainly don't do that at the clinic, but we so that would be a general surgeon, or your GP might be best for of course to start off with, to get into the system, because it might need washing, hygiene, smoking, not smoking. Often people here with these things are smokers. You must not smoke. It's not going to heal if you smoke. So non-surgical measures first, but certainly the surgical management of pilonidal sinuses tends not to be plastic surgeons. How long does a scar take to heal after having a mole, cyst, or lipoma removed? Right. Okay. Yes. So Hugo's joined. Oops. How long? So basically, broadly speaking, a skin lesion, so mole, cyst, whatever, a skin lesion, broadly speaking, and it depends a little bit on the area, and it depends a little bit on the tension on the wound, but as a ballpark, 5 to 7 days, the skin should be healed. So broadly speaking, 5 to 7 days, the skin's healed. The skin on the face heals a lot more quickly than the skin on the body. So that's why often you'll have stitches on your face and they can come out within 5 to 7 days. But on the body, it often takes longer for it to heal. And also the other thing which will be a factor in how long it takes to heal is the amount of tension on the wound. So if you've had a big mole cut out, then there might be a lot of tension on the wound. Whereas if you've had a lipoma removed, which is underneath the skin, there might be no skin removed whatsoever. So you might just have an incision in the skin and then the lipoma is taken out from underneath the skin. So there's a lot less tension when you have a subcutaneous lesion like a lipoma or a cyst compared to a skin lesion like a mole. So the ones with more tension will take longer to heal. And so the bigger they are, the longer they'll take to heal. And also certain areas, things like the back, the ankle, around the lower leg, the blood supply is not great. So the healing is a bit slower. So if you did have stitches in, we often use dissolvable sutures in order to avoid having stitch marks, which are little dots at either side of the scar. But if you do have kind of normal stitches with on either the scar and like the normal traditional what you'd imagine stitches to look like, those stitches need to be in for longer. So as I say, the face, they can come out in 5 to 7 days, the body 2, maybe 3 weeks, just to make sure the wound's completely healed. And the problem with doing that is it can leave stitch marks if you leave the stitches in for a long time. So you've got to think, oh, do I want stitch marks or do I want a wound that doesn't heal up? Now, what we normally do is we normally use dissolvable sutures subcuticular underneath the skin, so they don't leave stitch marks, and you can leave them long. They stay longer because they're underneath the skin, so they're dissolvable. So that's not normally what we do, but yeah. So the skin's healed in a week or so, but it takes months for it to mature. The scar goes a bit red, a bit active, a bit firm, and it takes. I normally say it starts about 3 months, 6, 12, 18 months for it to fully mature. So it's healed in a week or two. It takes 6 months or so to sort of mature, maybe 12 months to probably mature and soften and settle and go skin colored. That's often red to start off with. By the way, if you've got a question, you can ask, if anyone's got a question. So full disclosure, I'm on my last question. So the last question goes something like this. Can we remove a lipoma via liposuction? We can. Only a select. It's quite not that common to do it with liposuction. It can be done, but it's not that common. So the problem with removing a lipoma with liposuction, it would have to be a pretty big one, because a small one you can often take out through a relatively small incision. So it's kind of like, what's the benefit of doing liposuction? Because if you're going to use an incision about the same size, why don't you just take it out sort of normally, where you can actually see it and you can see the edges of it and make sure you get it all out. Although I did say earlier that you can sometimes have multi-loculated ones, but you can be a bit more reassured that you're getting out if you can see it and you can see the borders and get it out completely. But if it's a very large one, if it's in an area with bad scars, I remember I did one on the shoulder here, which is potentially an area of bad scars, a really big one. With liposuction is an option. Good thing about liposuction is it's just little stab incisions. Problem with liposuction is can't really send it for histology, or at least it's more difficult. You could potentially send a lipoaspirate for histology, but if you're worried about it, if you think it might not be a lipoma or be something else, you wouldn't really want to be doing liposuction, because you want to be sending that specimen off as a discrete thing so they can have a proper look at it and be absolutely sure what it is. So you'd have to be completely sure it was nothing worrying because of the histology side of things. The other thing is you're not going to remove any skin when you're doing liposuction, but that might be fine. But sometimes if it's tensing up the skin a lot, you can remove some skin to tighten the skin a bit, but it usually recoils pretty well once the lipoma is gone. And I guess the other thing is the sort of anesthetic. Liposuction is a bit uncomfortable. It's kind of like a sort of metal rod that we put in to suck the fat out, and so usually it's kind of like either a general anesthetic or local with sedation. whereas excision can often or usually be done under a local anaesthetic. It's not 100% because a very big one might need local anaesthetic or general anaesthetic, but you know, we've done some pretty big ones under local actually. So you can do fairly large lipomas under a local anaesthetic, but if it's kind of really, really large, then you might want to consider local sedation, and so that would make it more in line with the liposuction side of things. So I guess, yeah, no histology is the downside, and also a bit more difficult telling whether you got it all out because it's you can't really see it, whereas when you do it under direct vision, you can be more assured of getting it all out, although, as I said earlier, there's always a risk you can leave some behind if it's multiloculated, but it's there's usually quite a nice border with them, and you can be quite confident that you've got them all out when you're excising them, but you don't really have that benefit when you're doing liposuction. Like anything in life, swings and roundabouts, good and bad, but something we can certainly discuss. We're open to discuss, you know, open to make a decision with you, you know, what's best for you, what's right for you. So there we have it. So I've got to got a lot on, obviously, so I'm going to go and do all my things that I'm doing now, and if you do have any questions, feel free to ask. I might not answer until next week, and I will be back here next week with another thrilling installment. I think you all agree that was fairly thrilling. A thrilling installment of the live Q&A. Hashtag Ask JJ. Yeah, got any questions, ask me and I'll answer them. Adios amigos. Hasta la vista, baby.